Good afternoon. Thank you for the opportunity to present our research. Again, my name is Erik Deangelis. I'm one of the PGY4 general surgery residents at George Washington University. And again, the title of our project is Trends in the Utilization of Laparoscopic Colectomy According to Race, an Analysis of the NIS Database. We have no disclosures. So prior research has demonstrated that there is a benefit of laparoscopic colectomy over an open approach. Laparoscopy is associated with improved recovery after surgery as well as decreased rates of complications. Therefore, rates of laparoscopic colectomy are increasing. Prior research has also demonstrated, however, that race affects the likelihood that patients undergo a laparoscopic approach to their colectomy. However, it's unknown if increasing rates of laparoscopy have resulted in improved or persistent disparity in the likelihood of receiving laparoscopic surgery. Therefore, the purpose of our study was to analyze the rates of laparoscopic colectomy stratified by race over time. We wanted to determine if there was any racial disparity in the rates of laparoscopic colectomy, as well as to determine if there were any hospital factors that influenced the rate of laparoscopy. To do this, we performed a retrospective review of the National Inpatient Sample, or NIS database, between the years of 2009 and 2018. Our primary independent variable was race, which was defined in the database as Black, Hispanic, or white. Our now primary outcome was surgical approach, either laparoscopic or open. We controlled for covariates using multivariable logistic regression. We identified over 200,000 patients, again, Black, Hispanic, and white, as you see broken down on the slide. After univariate analysis, we determined that laparoscopic colectomy was used overall in 47% of cases. However, this varies significantly by race, with Black patients less likely to receive a laparoscopic operation when compared with white patients, and this was statistically significant. When we performed multivariate analysis, we identified several factors that were associated with increased likelihood of laparoscopy. We divided these into both patient as well as hospital factors. So patient factors associated with increased likelihood of laparoscopy included increased age, male sex, lower case complexity, private insurance, as well as higher income. Hospital factors included a central urban location of the hospital, hospitals that were located in the geographic south, medium bedside hospitals, and non-teaching status. After multivariate analysis and controlling for all of those covariates, we found that Black patients persisted in having lower adjusted odds of receiving laparoscopic colectomy versus white patients, while Hispanic patients had similar adjusted odds of receiving laparoscopic colectomy compared to white patients. When we looked at that rates of laparoscopy over time, we found that while there was a general increase in the probability of laparoscopy over the study period, Black patients remained less likely than their Hispanic and white counterparts to receive a laparoscopic colectomy. When we looked specifically at Black versus white patients and their adjusted odds of receiving laparoscopic colectomy, we found that in several years of the study, Black patients were at significantly lower odds of receiving laparoscopic approach. That was statistically significant in the years 2010, 11, 14, as well as 2017 and 18. So simply with the passage of time, these disparities weren't going away, they were persistent. So as a sub-analysis, we were interested to see how the race effect co-varied with hospital factors. We identified that Black patients were most likely to be treated in hospitals that were designated as central urban hospitals, hospitals that were located in the geographic south, and that were either medium or large bed size. If you remember back to a couple of slides, these were also the hospitals that were most likely to offer their patients laparoscopic surgery. Despite that, Black patients were most likely to be treated in hospitals that had higher likelihoods of offering laparoscopic colectomy. Black patients continued to have lower probability of receiving laparoscopic surgery, and that was across all of the hospital variables that we focused on. Despite our results, there are limitations to our study that we acknowledge. This is a retrospective review of a database. There are database constraints, including entry errors, missing data. There's a lack of granularity in clinical data as well. We're limited to the variables as they're defined by the NIS. We also did exclude other racial groups due to lower relative numbers. There are designations of Native American as well as Pacific and Pacific Islander and Asian patients, but their numbers were too low to produce valid estimates in our models. And there was also a code switch due to the, again, limitations in how you can identify procedures in the NIS. We did have to use ICD-9 and 10 procedure codes, and there was a switch from 9 to 10 version in October of 2015, which you may have noticed there was a drop in the probability of laparoscopy after those years. So there may be issues with coding or errors in the first years after adoption of those codes, or we might not be able to pick them up as readily. In conclusion, race was independently associated with the likelihood of laparoscopic colectomy, and Black patients were less likely to receive laparoscopic colectomy compared to their white counterparts. And this disparity was persistent over time, and importantly, there were hospital factors that contributed to this disparity as well. As always, there's more work needed to be done, in particular to understand why there is persistent racial disparity in the utilization of laparoscopy, how this relates to structural disparities, systemic racism, as well as the need to identify strategies to reduce and hopefully to eventually eliminate these disparities. But we do think that addressing racial disparity in utilization of laparoscopic surgery is important in order to optimize surgical care as well as to promote equity in medicine. Thank you again for the opportunity to present, and I'm happy to take any questions.